I'm going to talk about inequality in perhaps child human capital and what the consequences of that are for inequality more broadly. So I assume a lot of people here are economists. You probably know what human capital is, but I thought it would be useful to think about it from the broadest possible perspective. If you look up capital in a standard dictionary, you get a definition like this, that it's wealth in the form of money or other assets owned by a person or organization or available for a purpose, such as starting a company or investing, or more simply, just a valuable resource of a particular kind. So when we talk about human capital, we're talking about a particular form of wealth that's embodied in people. There's a lot of work done in economics on human capital. Most of it focuses on education as a form of human capital that generates some return. We think about people getting more education and then earning more income, for example. And child health, when it has in the past come up in this literature, usually comes up in the context of education. So people will be concerned, for example, that if a child is sick, they won't be able to get as much education, and that will in turn affect their earnings. But increasingly, child health itself has been recognized as an important form of capital that affects people's future earnings and other outcomes, and that therefore may contribute importantly to adult inequality. So what I'm going to talk about in this lecture are some of the highlights from this recent literature. Then I'm going to give a somewhat extended example of a policy intervention to extend child health insurance in the United States and the really long-term effects of that intervention on health and inequality. And then I'm going to talk about some of the directions for future research and especially highlight the importance of mental health as a type of human capital that maybe we haven't spent enough time thinking about. So to begin at the beginning, there is a large literature that was first in medicine, but increasingly in economics, about fetal origins. The idea is that the fetal period is an important period for child development that has consequences for the future. There are many types of shocks that can happen while somebody is still in utero, such as pollution exposure, nutritional deficits, maternal stress. And there's overwhelming evidence at this point that these effects are quite large. And since the period in utero is quite small, it offers an opportunity for targeted investments to reduce the impact of these types of shocks. Another important takeaway message from this literature is that both nature and nurture are important. So in the past, we've thought of characteristics that somebody was born with as something that was genetic. And the reason why that was important, how we viewed it, was because we tend to think about things that are genetic as things that we can't change. But in fact, what we see is that whatever somebody's genetic endowment is, environment is still important. More technically, you have a genome, but you also have an epigenome, which you could think of as a series of kind of on-off switches for parts of your genetic code. Things that happen in utero program the fetus for future life in a way that can be changed through manipulating the environment. So just as an example, this is a figure showing the relationship between mothers' birth weights and children's birth weights along the, let's see, have I got my, there we go. So along the x-axis here is the mother's birth weight, and along the y-axis is the child's birth weight. You can see there's an upward slope. So mothers who are bigger at birth tend to have children who are bigger at birth. But if mothers are living in wealthy circumstances, the child's birth weight is systematically higher than if the mother is living in poorer circumstances. Okay? So that's an example where you have an endowment, but the environment also matters. So I'm going to talk now about public insurance, since that's one of the most obvious policies that we have that we hope will affect people's health. And so the public insurance program that I'm going to talk about is called Medicaid. It's a program for low-income women and children in the United States. This program was greatly expanded starting in the late 1980s and in the 1990s. It mostly affected poorer people, so it was aimed at reducing health inequalities. And so it offers an opportunity, since it happened a long time ago, to see what the long-term impacts of that intervention was. Okay, so, and just to give you some idea about the size of this program, I'm comparing in this figure 3 of the largest welfare programs in the United States. The Earned Income Tax Credit is a cash transfer program that runs through the income tax system. The SNAP is used to be called food stamps. It's a nutrition assistance program. And then Medicaid, you can see, is just way larger than any of these other programs. So I think that's also true in European countries, that typically we spend a lot of money on health insurance. And so it's useful, I think, to think about it from an investment perspective. What are we getting for the money that we're spending? Okay, so a nice thing about this expansion is that given that the United States isn't always a tremendously unified country, it happened at different times in different places. What this figure is illustrating is the fraction of 18 to 44-year-old women who were eligible for Medicaid in the period between 1979 or 1993, or rather the change. So the darker places are places where there was a 50% increase in the fraction of women who were eligible, and then the lighter places are places that were more generous to begin with, and so there was a smaller increase in the fraction eligible. Okay. So the percentage of pregnant women eligible for Medicaid coverage went up from about 12% to over 40%. And one thing people are sometimes surprised to learn is that today about half of the births in the United States are paid for by the public health insurance program. So this is a very a program with a lot of reach. Okay. So I did some of the initial work studying the expansion of this program in the early 90s, and what we saw were immediate improvements in health. Specifically, we saw an 8.5% decline in infant mortality, and we could link that to some specific changes in the kinds of healthcare that people were getting. So, for example, we saw that there was a 50% reduction in delay in obtaining prenatal care among mothers in the highest poverty groups. So we could make a direct connection between people getting prenatal care and the reduction in infant mortality. So a really interesting thing about these expansions is, since they happened in the early 90s, those children are now 19 to 29 years old, so we can follow those cohorts and say, how did they do relative to the cohorts who were born just before them who didn't have access to these programs? And when we do that, what we see is some significant effects on a wide range of outcomes. Here, what I've shown in the blue bars are some effects that are statistically significant when you look at a sample of all children. You see a fall in chronic conditions, and you also see a fall in the number of hospital visits per 1,000. One interesting thing to sort of ask yourself when you see this is, well, what are the chronic conditions that affect people 19 to 29, what are the things that they end up getting hospitalized for? A lot of those things are mental health conditions. So this is already a clue that mental health conditions may be very important. If we focus not just on all children, but on poor children, what you see is a much broader range of effects. So you see larger decreases in chronic conditions, larger decreases in hospitalizations, but you also see increases in income, increases in the probability that they ever attended college, decreases in welfare participation, and if you directly try and measure mental health, you get an improvement in terms of a score for mental distress. Okay, so what we're seeing is a really long-term improvement of these cohorts relative to cohorts who were not eligible for public health insurance coverage. Okay. So I talked about expanding coverage for pregnant women. There were also expansions of coverage for young children, which are illustrated in this figure. These expansions were phased in at different times for different age groups of children. First, really young children were covered, then older children were covered. And you can see that the coverage levels go up from between 15 to 20% of children to over half of children. So again, today, about half of U.S. children are covered under public health insurance programs. What this means is that most children in the U.S. do have health insurance coverage because the other ones tend to be covered by private health insurance coverage under their parents' plans. So we had this huge expansion of health insurance coverage for children. Okay. One way to try and look at the effect of that is to compare mortality rates in the US and Canada for different age groups. So what I want you to keep in mind is that, I'm from Canada, and we like to think that we're really different from Americans, but there are many ways in which Canada is quite similar. Some of the key features, the large distances, the fact that people drive a lot, which is important for mortality because car accidents are an important cause. The kinds of medical technologies that are available are very similar. Doctor training is quite similar. So there's a lot of similarities. A big difference is that Canada has had public health insurance since the 1970s for everybody. And in the US, what I've been talking about is an expansion of health insurance for children, but we know that the expansions of health insurance to adults didn't occur until very recently with the Affordable Care Act in 2014. Okay? So we can think about US and Canadian adults, where Canadian adults have health insurance and American adults don't have access to public health insurance. And then we have children, where the Canadian children have access and the American children got access in this experiment that I'm talking about. Okay. So in order to look at the effect of that over time, what we do is we look at counties, and we rank counties from the richest to poorest, and then look at groups of counties that each account for about 5% of the population. And we can do this for each census year in Canada and the US. So just to illustrate the kind of comparison that we get, here, I'm arranging these counties by poverty percentile. So here is 0 are the richest places, and 100 are the poorest places. And then we have a mortality rate per 1,000 for 0 to 4-year-old children. Okay? So here, Canada is going to be marked in red and the US in blue. The first thing that you see is that the line slopes up. What that means is that mortality rates are higher in poor places than they are in rich places. The thin lines here are for 1990. So in 1990, in rich places, mortality rates were quite similar for children 0 to 4 in Canada and the US. But in poor places, they were much higher in the US than in Canada. So you can see this huge gap. Okay. Going forward to 2010, after these expansions had been in place for some period of time, what you see is that mortality fell for all places in the US, but it falls a lot more for the poor places than for the richer places, and the line becomes flatter. Mortality also falls in Canada in a much more parallel way. Right? So you can think about there's technological change in medicine over time. We expect mortality rates to fall as medical care gets better. If you have a more equal system, you get a flatter curve because mortality falls for everybody. Right? In the US, what you saw was this huge inequality is greatly reduced, the line becomes flatter, and it becomes much more similar to the mortality rate in Canada. Okay, so children got health insurance in the US, and their mortality rates become much more similar to what we see in Canada. Okay, just comparing to some other age groups, a really striking one is for females age 40 to 44. In the US, there was no improvement in mortality for that group in either rich or poor places. In Canada, there was some improvement in mortality, but the gap that you see between, especially in poor places, between Canada and the US is just as big in 2010 as it was in 1990. Okay. Similarly, for people aged 60 to 64, you see declines in mortality, but you don't see any narrowing of the gap between Canada and the US. So the point of this, what I'm trying to get at, is that you saw convergence in mortality rates in the US for children to lower Canadian rates in the one group that got public health insurance and not in the other groups which did not get insurance. Okay, so this is some indication that public health insurance is helping to reduce the mortality rates among children in the US. Okay, so I've discussed how the Medicaid expansions reduced mortality and improved health among poor children, but you might ask, does that reduce inequality among survivors? It doesn't have to. I mean, mechanically, if you save the lives of people who are sick or have some sort of disability, they might earn less than other people. So you could end up with a sicker pool of survivors. But again, the availability of administrative data lets us look backwards to see what the long-term effects are. Okay. A peculiarity about these expansions for children in the US was that only children who were born after September 1, 1983 were eligible. If you were born on August 31st, 1983, then you were just out of luck in terms of these expansions. So a lot of people have used that discontinuity to try and see what the effect of insurance coverage was on a wider range of outcomes. And again, there's a lot of difference across places in the years of Medicaid eligibility that people got because of these expansions. Okay. So this figure is illustrating increases in the amount of tax paid according to how many years of Medicaid eligibility children got. Okay, so here, the tax paid at age 19 is normalized to be 0. And I have 3 lines. One is for the poorest families, and then one is for wealthier families. And what you see is that for each year of Medicaid eligibility, the tax paid by age 28 goes up by about $1,700. That's for the poorest families. And then even for the richest families, it looks like there's some impact, which may be because one of the effects of this legislation was that from the point of view of medical providers, every child was now covered. So you didn't have to worry when a child came to the hospital that care that you provided might not be compensated. All care was going to be compensated by insurance. And so you see some general equilibrium effects of this where there are benefits for high-income people as well as low-income people from everybody having insurance. Okay, so what I've told you so far, I think, is all very well established. And now I'm going to talk about some work that's a little bit more speculative about what are the mechanisms for these improvements in earnings. I think that mental health may be one of the most important mechanisms because mental health is so important for determining adult outcomes, especially whether people work at all. Many mental health problems are first observed, or at least first observed to be really disabling people early in adulthood, but we know that they start often in early childhood. And we know that conditions, even prenatally, are associated with some types of mental health problems. I'm going to show you some evidence that mental health problems are very common, and also that they directly map into traits and skills that we know are useful in the labor market, such as focus, internal motivation, stress tolerance, and ability to get along with others. So this data is from something called the General Social Survey in the US, where they ask the question shown here at the bottom. Now, thinking about your mental health, which includes stress, depression, and problems with emotion, how many days during the past 30 days was your mental health not good? Okay, so you could think about answering that question for yourself even. This striking thing here is that there are a lot of people who answered that they had, at least one day when their mental health was not good. That's between 40 and 50% of these respondents. And these are all employed respondents, I should say. If you look at the group with the most bad mental health days, that's about 15% of the population. And it's also fairly constant over time. So we have 15% of workers reporting that they had 10 days or more last month where their mental health was not good. Okay, so that's a significant burden. Of course, this is self-reported, and you may think, well, I don't really know what that question means. Another way to think about the impact of mental health conditions is to look at emergency room visits. So in the United States, if somebody's having a mental health crisis, they are universally told to go to an emergency room. And so if you look at the fraction of emergency room visits that involve some sort of mental health indication, it's about 13.4%. Okay? So overall, we have 380 visits per year per 1,000 population, and 13.4% of those have some kind of mental health indication. Now, mental health indications also include substance abuse. If you look at people where that was the only mental health problem listed, that's about 2.8%. So now I'm breaking up this 13.4%. But you have 5% of people showing up with a mood disorder, so that would include something like depression. You also have 5% of people showing up with anxiety disorders. Apparently, people who are having a panic attack often think it's such a horrible experience that people think that they're having a heart attack and will show up in the emergency room. So we have an awful lot of people showing up in the emergency room with mental health problems, which is another indication that these are very common. Okay. So as I mentioned, mental health problems often begin early, and they do impact educational attainment. This figure is summarizing results from survey data for both the US and for Canada, where we had a measure of child mental health in early years, and we're looking at middle school achievement. So what you see is that children who were diagnosed with ADHD or another mental health problem in both the US and Canada are more likely to have grade repetition, have lower math scores, lower reading scores, and are more likely to be in a special education program. Okay, so you can already see the effect of that in middle school. And then asking, well, what's the longer term effect of having mental health problems in early childhood? We used Canadian administrative data to link children with those diagnoses in early childhood to future outcomes, and also to compare the impact of physical health problems and mental health problems. Because remember, I'm arguing that mental health problems might be particularly important, so it'd be useful to show that they actually have more of an impact than some common physical health problems. So we look at the impact of diagnosis and treatment at 4 different age ranges on future outcomes. The outcomes that we can look at are whether children were on welfare after age 18. So the way the system works there, your family might be on welfare when you're younger than 18, but when you turn 18, you can go on welfare in your own right. Also, whether you're kind of on time in school, whether you're in grade 12 by age 17. And also, the system there is such that you have to take certain math courses in high school in order to qualify to go to college. So if people aren't taking those courses, then they're not on track to even be able to go to college. And that's another thing that we could measure. So this figure is showing, well, what's the effect on one of those outcomes, which is whether people were on welfare after age 18. The orange line here is for the children who had mental health problems at 0 to 3, 4 to 8, 9 to 13, and 14 to 18. By way of comparison, we have children who had some kind of major injury and children who have asthma. Those are 2 of the most common physical health problems. So those don't have much of an impact on this outcome, but you can see that having a mental health condition, especially in the teenage years, is having a major effect. Okay, similarly, if we look at whether they were taking the math courses they need to go to college, the physical health problems have a little bit more of an effect here, particularly in the teenage years, but mental health problems are having a really large effect. So the kind of striking takeaway here was that common mental health problems were much more predictive of poor adult outcomes than common physical health problems. We know from a lot of literature that prenatal conditions can place children at higher risk of poor mental health. So some of the most dramatic evidence of that was from the Dutch hunger winter, where there was famine in the Netherlands because of the Nazi occupation. Infants who are in utero and affected by that are more likely to have schizophrenia as adults. Similarly, there's been some other research linking exposure to war in utero to schizophrenia. So schizophrenia is a very severe mental health condition, somewhat rare, thankfully. You can also link fetal health to more common conditions. So for example, using a large sample of all the Danish twins, you can see a relationship between birth weight and whether children have ADHD. So in twins, usually one is lower birth weight than the other. So you can see that the lower birth weight twin is more likely to have ADHD than their own twin, who is of higher birth weight. Okay. Another example like this is a paper using Swedish administrative data and looking at the effect of having a death in the family during pregnancy. They compare the effect of having a death in pregnancy to the effect of having a death after the pregnancy. Right? So you're looking at samples of families where they all experienced a death in the family and the disruption for that, but the difference is that in one case it occurred during the pregnancy, and the other case it occurred just after. And following the kids who were in utero for the mom who received that shock, you see that the children are 25% more likely to be using an ADHD drug in childhood, and that when they get to adulthood, they are 13 and 8% more likely to be using drugs for anxiety and depression. So I think that's some of the strongest evidence that we have to date that some of these very common mental health conditions can be affected by conditions in utero. Okay. So most people find that fairly depressing, no pun intended, just because it suggests that things that you can't really do anything about ex post are having a long-term impact. So a question is, are there interventions that we can make which would have a positive impact? So I've been doing some research looking at that. One program that we looked at is called the Supplemental Nutrition Program for Women, Infants, and Children, or WIC. As the name suggests, this is a program that gives people access to nutritious food. It also gives them access to medical care, and it's really more of a sort of global support program for pregnant women. So we look at women who got this program during pregnancy, and then we follow their children to the ages of 6 to 11 and say, well, how are those children doing in terms of some common mental health conditions? And what we see is a reduction in mental health conditions of between 6 and 10% for children who participated in this program prenatally. Okay, so another question one might have is I began my talk talking about health insurance and improving conditions for pregnant women. We would think that that should have improved mental health conditions, and we saw some evidence that that was the case. But we hear a lot about how child mental health is getting worse, right? And an important factor there is that diagnostic standards for many conditions are changing, and also that when you give people access to health care and screening, if you do more screening, you're going to find more cases. So you have more access, which leads to more screening, which leads to more cases. And we saw very direct evidence of this in one sort of case study of South Carolina, the American state, where what we saw was that increases in ADHD prescribing, which is this blue line here, were all accounted for by increases in prescribing in the Medicaid caseload and none in private health insurance. So that's this green line, which is pretty flat. So it looked like more kids on Medicaid in South Carolina were getting prescriptions for ADHD medications. So that led us to ask, well, what was changing in Medicaid? What was changed was a change in the way that providers were reimbursed. So providers stopped being reimbursed on a fee-for-service basis and were given one capitated payment instead. A key thing is that the capitated payments were higher if providers were dealing with kids who had a chronic health condition. So we gave the providers an incentive to screen for chronic health conditions, including ADHD. Also, providers were penalized for not screening. Okay, so there was sort of a double incentive to do screening. And so we look at the effect of that in basically all the kids on Medicaid in South Carolina. We can look at that in two different ways. One of them is to look at children who were in Medicaid just before the change and compare them to children who are in Medicaid just after the change. And the second thing is to follow an individual child and say, if this child was in Medicaid and we change the way that their own provider is reimbursed, what happens to whether they get screened and treated? Okay, so what you can see here is that the trend in well-child screenings is almost exactly the same as the trend in ADHD diagnoses. So the screening seems to lead very directly to the diagnoses. We also see other evidence of increases in access to care. And so this is in the models where we're following the same child over time. We see that those children were more likely to get well-child screenings, more likely to get developmental screenings, more likely to get vaccinations. And, these are all kids who are on Medicaid. They're all supposed to be vaccinated already. right? So this is just showing if you give the providers an incentive to do a better job, they do that. Kids get more sick visits. And then we see increases in ADHD, we see increases in depression, but we also see increases in other chronic conditions like asthma. We even see increases in the number of children being treated for things like mild infections. This one is interesting because the providers don't get paid anything extra for treating that kind of thing, but you still see more treatment. Okay, so things are a little bit more hopeful than the fetal origins hypothesis would suggest, in that there's evidence that a lot of programs can have a positive effect. Once children have a condition, we think that it's very important for them to get treated. But now I'm going to sound negative again. We don't have a lot of evidence about the efficacy of different kinds of treatment for mental health. Here, I think just as the United States is a good laboratory for looking at effects of insurance because there's a lot of variation, it may be a good laboratory for looking at the effects of different kinds of treatment for children because, again, there's a huge amount of variation. So one way to look at that variation is here, where I'm looking at the fraction of the number of antidepressant prescriptions per 1,000 children by gender. And you can see that if I just rank counties, there's a lot of counties that have 0 prescriptions. So that's about 15% if you're looking at boys and around 8% if you're looking at girls. But then there's this long right tail where they have almost as many prescriptions as children. Okay, so there's a lot of places where there's a lot of prescriptions being written for children in this age range. Looking at it on a map, this is a map showing different counties of the US. And here the shading goes from 0 up until over 967 prescriptions per 1,000 in the darkest places. Okay, so there's a lot of variation across places in whether children with mental health problems are being treated with drugs or not. There's some similar variation in whether they're getting therapy or not. And that's one of the things that I'm trying to look at in my current research is what the impact of those different kinds of treatment are. Okay. One thing that's disturbing about this variation is that there is mixed evidence of the suitability of these drugs, especially for children. This is the black box warning that the Food and Drug Administration requires to be given out with all mental health drugs. This is one for Lexapro. And the major point is that antidepressants in people under 24 could actually increase the risk of suicide rather than decrease it, especially in the short term when people immediately start taking them. Okay, so the map shows that there's this widespread use of antidepressants despite possibly serious risks and mixed evidence about the efficacy. Again, for children, there's few molecules that have been specifically approved for use in children, so most of the use is off-label, and I think that's the same everywhere. And there's very unclear implications of this treatment on what people's even short-term effects are, let alone long-term effects. Okay, so I'm going to summarize and conclude at this point. What I've tried to argue is that child health is itself a very important form of human capital. Healthier children live longer, they're healthier, and they earn higher wages. Improvements in physical health are certainly important, but there's, I think, new understanding of the importance of mental health and that it's especially important for having a productive workforce. Mental health diagnoses in children are increasing. That's in part due to different diagnostic standards, different screening standards, and there's a lot more treatment and basically trying to figure out what is the effect of that treatment is a fairly urgent topic for future research. So I'll end there and take questions.